So good afternoon, everyone, and thank you for joining us at the very first session of the Be Well Texas Systems and Sustainability Echo. My name's Andrea Roche. I'll be facilitating our discussion today. I want to welcome you all to the new Systems and Sustainability Echo and tell you a little bit more about it. So unlike other clinically focused Echo series that you may be familiar with, even from the Be Well team, in this space, we're going to focus more on organizational and implementation challenges related to delivering substance use disorder services. So our goal with this series is to really create a learning community to strategize around system-level challenges in substance use disorder treatment programming. And this includes a wide range of topics: workforce or leadership development, sustainability, implementation of new programs, outcomes measurements, and much more. So the series is designed for leaders in health and behavioral health care, as well as any champions, really, looking to influence positive change in their organizations or systems. So the ECHO series will follow a pretty standard structure for these sessions. We'll always start with some introductions of our team and then do a brief evidence-based didactic on a key topic related to SUD systems and sustainability, and then share some Be Well program announcements. And following that, we'll hear a case, a systems case presentation from a member of our learning community. That's all of you. And we'll discuss it as a group. And this is really the heart of the ECHO model and of that all teach, all learn form of telementorship. This is a space for you to share your thoughts, your questions, resources, and lessons learned with your peers and colleagues. And we'll wrap up the hour with a quick summary of key recommendations made by a member of our hub team. Any questions? Okay, I'm excited to get started. So I do have a little bit of housekeeping before we get going. We are recording these sessions, as you saw when you entered, for later distribution through the Be Well YouTube channel. And any info you put in the chat, though, that will not be shared on those recordings. To help us with attendance and accurate record keeping, we do ask that you enter your name, your affiliation, and your email into the chat function. To navigate to that, it's just in the bottom menu bar of your Zoom window. If you've joined by phone only, we might call you after the session to confirm your attendance. But we appreciate all of you in helping us capture this record. And a little bit more about housekeeping, please do stay muted unless you're speaking, and we do encourage you to speak. If you've joined by computer, the mute button is in the bottom left of your Zoom window. If you're on the phone, just press *6. We encourage everyone to join by video for the discussion portion of our sessions, but we're happy you're here to learn with us regardless of how you are able to join. Also, please do share your perspectives in today's conversation. You can speak up, like I just mentioned, or use the chat feature to share comments and questions throughout the didactic, the case presentation, and the discussion. But please note, whether you're in the chat or you're unmuting, no protected health information is allowed in either format. Towards the end of the session, the Be Well Texas team is going to send out a link to an evaluation survey. I want you to fill it out for a few reasons. It gives us your feedback on how to refine and shape these sessions to address your priorities. And it also allows you to access free CME for your participation. And then maybe the most important reason, all participants filling out the survey will be automatically entered into a drawing for a $30 Walmart gift card. I'll send out another reminder about that a little later in the session. So our didactic today shares tools and sustainments of practice implementations and improvements. And then following that, we're going to discuss a case presented by Dr. Kathy Hudgens with us today. But before we get into the introductions, we're actually going to start with a quick poll of all of you to learn a little bit more about what you'd like to get out of this series. So Carly, with our Echo IT, would you mind launching poll 1? And this is a free text response. I think you have up to 500 words you can enter. So please do tell us everything you'd like to gain from these sessions. Carly's telling me we've got a quarter of our responses in, so we'll give it another 15, 20 seconds. I've got eyes on the inside here telling me. And if for whatever reason the poll function isn't working for you, this is a response you can also add over in the chat. So anybody who might have joined in the past minute or so, we just have a poll out to attendees, what you'd like to gain from this series. If the poll pops up for you and you're able to answer there, that's great. Otherwise, just throw it in the chat. We'll give another 15 seconds. I'm waiting for a round number percentage, Carly. All right, I think we're there. Okay, Carly, go on and close that poll. And let's get started with the rest of our session. Thanks to all of you. I know we don't typically do that in the Be Well series, but we really are trying to learn how we can shape this series moving forward. We'll have another poll a little bit later on in the session. All right, so let's start with some introductions of our hub team. I'm going to ask first for Leslie to introduce yourself.
Hi, everyone. I'm Leslie Manson. I'm a consultant for integrated care practice transformation. I have an expertise in building fiscally sustainable healthcare interprofessional teams. And I also work at Arizona State University. I'm an associate chair of integrated initiatives there, a program admissions, and a degree director. So I really appreciate being part of this team here. So thank you very much.
Thanks for joining us, Leslie. And Kathy.
Hello, everyone. Thank you so much for including me in this wonderful series. I am an integrated care and program building consultant. I'm the former executive director for the Center of Excellence for Integrated Care, and I'm also an affiliate faculty member with Arizona State with Leslie at the helm. I have my background is working with healthcare systems and behavioral health systems to build integrated care and substance use treatment programs, and am currently working with a group that I'm going to be presenting in a little bit.
Thanks so much, Kathy. And Matt.
Hi, folks. It's good to be here with you today. My background is originally in clinical social work in both substance use and mental health services. Also spent time as an agency administrator and as a governmental planner. Currently, I'm working as a consultant both in implementation science environments and in quality improvement. So it's good to be with all of you today.
Thank you, Matt. Andrea.
So my name is Andrea Hevler, and I'm a project coordinator for ECHO, and I'm here at UT San Antonio. Thank you.
And Adrian.
Hello, Adrian Lindsay. I'm the director of the Center for Substance Use Training and Telementoring here at Be Well, Texas, that oversees all of our ECHO programming and other online training. And I just want to mention one of our hub members who couldn't be here. She unfortunately ran into a personal emergency, but some of you may know Bea Courtois. And she oversees our provider network for the whole state and has been working in the Texas health and behavioral health system for 20 plus years now. She's going to bring a wealth of experience to our hub as well. So she'll be with us next month.
Thanks so much, Adrian. Well, let's jump into our didactics. Matt, you're presenting today. And when you're ready, take it away.
Excellent. Thank you. So I am going to spend about 15 minutes sharing some ideas with you today. Then we'll have a few minutes for questions as well. On the front end, as we get started, I just want to, as was reflected in some of our initial comments, to think a little bit about how this is different from perhaps, say, a clinical kind of an echo opportunity. Obviously, in both cases, we need to have some trust and some sharing, and there's some vulnerability that's required when people talk about their own experiences. I think one of the differences is that sometimes with systems level efforts like this and conversations around systems issues, there can be some concerns about competition issues or customers' perceptions if we share some of these concerns more publicly, maybe some of our contract relationships or market share issues that can come up. The premise that I like to bring to this kind of a conversation or any kind of a collaborative effort like this that is at a systems level is to appreciate the acknowledgement of a need for improvement. Regardless of whatever the status quo is, we talk about going from good to great. We can also talk about going from great to greater. Regardless of wherever you are right now, high quality service systems are constantly acknowledging their need for quality improvement. And so putting forward your need for quality improvement in a public forum like this, from my perspective, is a statement of your dedication to quality, and it reflects that orientation to the broader community. So that's hopefully you can share that spirit as we do this work today and as we continue to work together going forward. So let's talk a little bit about some handful of key tools related to sustainment as it relates to practice implementation and improvement. So everyone knows the story of Sisyphus, right? This mythic character who is forever doomed to roll the rock up the hill. And in many of your environments, of course, you've had a lot of familiarity with rolling rocks up the hill that tend to fall back down. So I want to talk with you about some key areas that can build what we might think of as a frame to hold that rock so that it doesn't keep rolling down the hill. This is not an all-inclusive frame. It's just a few ideas that are designed to prime the pump for you to think about issues related to sustainability. So first I want to talk with you just a bit about this notion of team. And I like to use the word team as more of a verb than a noun, as in teaming. We often find that we use language that says, oh, we just hired someone, we have a new member of our team. I like to think of it like this. No, you don't, not yet. You just hired them. They're not a member of your team. They can't be a member of your team because they haven't done any teaming with you. So action is required. I say this, we all know this, but we get complacent because we orient ourselves toward the hiring and say, well, okay, we're done, we're good, you're on board, you're a team member. Not yet, not yet. You have the capacity now to become one. So what do we need to do to have you pull together with us, to have you be working in alignment with us, those of us assuming we have an active functional team, which is not always the case, right? We have to make sure we're mindful of whether or not we're teaming at all within our group. Sometimes we're pulling in different directions and we're not pulling consistently with each other. And do we have that shared sense of mission or purpose to achieve a desired effect? Those are kind of the core ingredients of team. Think with me for a minute about some of these strong traits of teams. Maybe ask yourself how you might rate your own experience within your own team environment related to these things. Do you trust each other? Do you communicate and share information, ideas, knowledge, particularly the challenging information and knowledge, some of the struggles or challenges that relates back to what I was saying at the top of this conversation around the notion of being able to talk about the places where we need to improve, the places where we might be struggling. Is there a focus on details? Do we dig in on the nuts and bolts diligently to try to understand what we need to do? Do we have diversity? And I mean diversity in the broadest sense of that word. Do we have people, participants who have a wide range of experiences and skills, backgrounds, cultures, any kinds of experiences that they bring to the table that help us to have different lenses, different points of view, different perspectives? I always say that if you have 5 people on a team who have identical experiences or close to identical experiences, it's kind of like only having one person. We really don't have much in the way of that breadth of knowledge and experience that we need. We want as much diversity on our team as we can get. And then number 5, do we have clear goals? Do we have a clear mission? Sometimes the obvious missions go unstated because they are seemingly obvious, but That's, I think, something we are neglectful of if we're just stating, if we're failing to state those overt missions to the team and have it be a part of our conversation and driving our interactions. And does the team learn? Does it have this, what a lot of folks call agility? Does it adapt and adjust course? Is it comfortable with making changes? A lot of what we'll be talking about together is this openness to change and this openness to adaptation. So teams is our really strong concern, and I hope you can focus in on your teamwork as we're having these conversations. Another key issue is priority. Not up until not that long ago, the idea priority, the word priority was not a plural word, it was a singular word until 100 years ago. 200 years ago, no one said priorities. Today we say priorities every day, which is, in my thinking, a problem. So we're always asking these questions. How can we manage to juggle another thing? We're always asking ourselves this question. When we think about sustainability, this is a serious problem because we're continuously adding another thing, and we have this expectation that we'll keep doing all of them. So Warren Buffett, you may be familiar with Warren Buffett, has this little strategy, which is you make a list, a big list of all your priorities, and then you pick the top 5 off of that list. And then Warren Buffett would say, what do you do with the rest of the list? And most of us would say, well, we'll do those things when we get a chance to do them. And Warren Buffett would say back, no, you burn that second list. You avoid those at all cost, because the only way you'll be able to do the important things is if you stop doing the things that are lower on the list. Now, that might sound like a bit of a radical orientation. There is a need to maintain a wide array of activities in most of your environments. But maybe the better question is for us to say this: what should we quit? That's the hard choice when it comes to establishing priority that a lot of us try to avoid, because it's a painful and difficult conversation to have as a system. So this is one I would think of you, that I would encourage you to consider as it relates to sustaining your priorities. What should we quit? What are we doing that we should not be doing? As often said, if everything is a priority, then nothing is a priority. So asking yourself that question, making that long list. I like the Warren Buffett strategy to make that long list and say, what's at the bottom of this list? If we rank order this whole list, what's at the bottom? And why are we holding on to it? Do we need to hold on to that? So that's as I said, can be a painful question, because someone's always going to be voting to hold on to that item on your team. There's never an item that everyone will have consensus and say, yeah, that's a waste of time, we should never do that, because it's there for a reason. Somebody put it there. You may have a situation where that person's no longer with your team, so there's an easy win for you in terms of shrinking the list. But for the most part, there will be folks dedicated to every item. So that's the hard process that I encourage you to try to work through. Let's think about measurement. What do we mean by data democracy? Data democracy means that everybody has access to data. Everyone has access to the information. I don't know how many times I've had the conversation in systems with whom I've been working where I'll ask someone who may be working in a sort of a line staff capacity, maybe a direct service capacity, and I'll say, well, tell me about your quality improvement plan or your strategic plan, or tell me about your the data metrics that are driving this program. And they most of the time say, oh, I don't do that, that's not me, you got to talk to, and then they point to a manager, a supervisor, a QI, depending on the size of the organization and the nature of the organization. And I think that's a bit of a tragedy that we haven't included that person in the mix, that they don't say, yeah, we've got a chart on the wall in our room where we have our meetings, our team meetings, and we're watching this metric, and we're seeing how well we're engaging our clients. We're seeing how well we're sustaining our continuation of folks. We're trying to increase continuation or retention of clients past 4 weeks, I'm just making up the numbers here, depending on what the priority might be for that organization. And we're at 70%. We're trying to get it to 85%. Now we know we've got a team that's being driven by data. They're a part of data-driven decision-making because the data has been visualized. There's maybe a simple dashboard of 2 or 3 key metrics for that person, for that program. Now we really have a data democracy happening. So to ask yourselves the question, to what degree do you have that sort of a model or orientation where everyone's included in those data questions? Also, let's think about policy. Again, we're kind of moving our way swiftly through a few key ideas, just priming the pump with these ideas. The notion of the new becoming the norm in terms of policy changes or implementation of policy. I often use this metaphor where I think about new practices and then efforts to sustain a new evidence-based practice implementation or a new policy or a procedure or a process improvement. And often it feels like pouring a big pitcher of water into a dry beach. And we pour this best practice into our program and it just vanishes on us. And many of you have had that very frustrating experience as it relates to sustainability. So one way to think about this is to consider that evidence-based practice or that new improvement, whatever it is, and think about how you can build those policies and procedures which are going to be the container for that water, right? This is precious stuff. This water is really important and valuable to us. How do we hold on to it? We can't just dump it into the program, which is one of the big challenges of best practice implementation. We tend to just sort of say, let's learn it, now let's do it, without having created the container to hold it, the policies and the procedures and the structure that's going to hold that practice for us going forward and sustain it for our program. And of course, tremendous loss of opportunity, tremendous resource loss. Our return on investment after having learned it gets lost, right? So this is an important critical moment when we learn that practice and then start to implement it. Do we have the capacity to hold on to it? So to recap and think about those key ideas, engaging in active teaming. Are your folks working together as a team, and how are you kind of monitoring and measuring the actions that are team activities, and how are you effectively coaching that team as it does its work? Are you trying to figure out what you can quit? I use that word intentionally because it's a little bit of a jarring word. What you can quit. What are the things that you should quit? And to make those hard choices. Do you have a data-driven team process? Do you have that data democracy where it's inclusive and engaging for all parties, and you're speaking a data language that everyone can understand? And lastly, do you create those new norms through policies and procedures which become that really strong container for your best practice implementation so that it is, in fact, sustainable for you? So thank you for listening and reflecting on those ideas. I know we've preserved some time for some Q&A.
That's absolutely right. If you could stop your screen share, Matt, and we'll open up the room. That was a great primer on thinking sort of strategically and sustainably, about practice improvement. Exactly what Matt said. Any questions from the Learning Network? That's quite all right. I think we'll see some of these themes echoed in our case for today. And I apologize, we're going to make echo puns a lot without meaning to in this series. Carly, if you don't mind sharing the announcement slide deck, I want to share some updates from the Be Well Texas program. So Be Well Texas is a welcoming environment with caring professionals who are ready to help people start or continue their journey toward recovery. Be Well Texas is committed to expanding equitable access to compassionate, evidence-based treatment and care for substance use disorder throughout Texas. The Be Well Texas Clinic offers low-cost, self-pay, and no-cost services for patients affected by substance use disorder and also has insurance options available. Next slide, Carly. So coming soon, some new ECHO programs, the Public Safety ECHO for public safety professionals and a First Responders ECHO for the SUD ECHO, and a First Responders ECHO, and then an SUD Interventions for the Behavioral Health Workforce ECHO. And next slide. But remember, we're still continuing to offer an array of other programming, including TexRx, Recovery Support Services, Shout, and a Harm Reduction ECHO series. And with the new one-time registration link for each of these series, it's really easy to have all of your ECHOs, all of these ECHOs on your single calendar. You can register for any and all of the ECHO programs at bewelltexas.org. We'll throw that link over into the chat. All right, before we get into our case, we do have one more poll, again, to get a lay of the land here and learn a little bit more about the challenges you all are facing. So, Carly, thank you. You read my mind. So you should have seen a poll just pop up. Again, another free text answer. You have 500 words, but tell us, what are some of the common challenges you've encountered in your SUD treatment implementation efforts? And I don't know if anybody's having issues, but if you are having issues seeing that poll, you can also just throw that answer over into the chat. We'll give just another half minute more to get that response percentage up a bit more. What challenges are you facing in your current implementation efforts? All right, I'll have you wrap up in just about 10 seconds. Finish that sentence or end in a fragment. That's also fine. We'll understand. And this actually helps us to shape future didactics, learn a little bit more about how we can refine the case forms, and get a good sense of what challenges folks are facing out there. Because as I mentioned before in the introduction, this series aims to address a wide array of implementation challenges. Well, we've gone over the halfway point of our response, so I'll ask Carly to go on and close that poll. Again, if you're still thinking about your response or something else comes up and you've already enter, throw it in the chat, and we want to hear what challenges you're facing. All right, I'm very excited to move on to the next part of our ECHO session. This is the case presentation, and I'm going to turn things over to Kathy, who will talk us through our systems case form. Carly, if you wouldn't mind sharing the case form. And Kathy, when you see that, just take it away. Tell us more.
So, hello again. I have been graciously offered the opportunity to share this case on behalf of an organization I've been working with for about 3 years. the last two of which during the pandemic, I sat in as part of their leadership because I certainly was not going anywhere. So it was in my region. And then recently have gone back to consulting, and they've hired a leader for that program. So it is a very excited program. It really is excited about having this vertical program to address opioid use disorders. It is a vertical, meaning that it has a very prescriptive framework for medication as well as counseling. And that prescription for the framework comes from the state reimbursement. So for this program, in order to be a preferred OBOT in the state, you have to have certain requirements, including a waivered prescriber, obviously, but you also have to have a coordinator who is above a bachelor's level, who is licensed. You have to have for every patient, you have to have a weekly staffing. There's all kinds of different paperwork, plan of care. They have to have weekly group. They have to have individual counseling when needed. And they have to have linkages to higher levels of care that are identified with agreements in the region around that person. So being an FQHC, a federally qualified healthcare clinic, that primarily treats patients who are underserved. It is part of a safety net, and it is primarily African American and Latino. So this being the sort of patient base with COVID-related increases in substance use disorders and concerns and mental health issues, it was building when that hit. And then staffing became a problem because they lost staff. They hired several people that were not aligned in philosophy. Before I got there, they hired someone who they did not ask about harm reduction philosophy, and that person actually did not believe in harm reduction, which is curious, but which became a barrier because it was never spoken. And Matt talked a lot about teaming, and teaming has to come with communication about the philosophy, especially in substance use treatment, and so making sure everyone is aligned. It took them 2 years to find a certified peer support specialist, which is also a requirement of that framework to be a preferred OBOT for reimbursement in the state. Certification in the state is very difficult to get because there are quite a few hours. You have to have supervision. You have to be, able to go through the course. And you also, this organization also, yes, and it is not a rural area. This organization also had difficulty finding someone who they finally had to waive the policy to not hire a felon, because that comes with some of the peer support work that they do. Some of these folks have ended up in jail because of some of the things that happened during their active addiction. So finally, they were able to waive that, but there were so many barriers to getting the staffing up and running. They also did not have someone to run the group consistently. They lost 2 staff members during the pandemic who did not want to work in a health center to do behavioral health. I know some of the best ones, and actually the one they hired is amazing. She is just stupendous, but still trying to get up and going. So with all that being said, there was very little recruiting that could happen because the patient base was, if you want to just forward this. So the census was low. The referrals for external referrals from partnering agencies did not happen because the coordinator they hired did not go out in the community during the pandemic for fear of getting COVID. That was not conveyed to anyone in the organization, so that marketing and partnership development was not happening, and no one knew. And then, so that was also, part of the whole communication piece. The state changed the way they reimbursed based on registering the providers through a portal. They shut the portal down, didn't tell the organization until 6 months later, and they were continuing not to be reimbursed, but the billing folks did not tell the administrator and the coordinator that they were not being reimbursed. So 6 months of lost revenue. And then internal referrals, very difficult because there was stigma and a misalignment of the providers not understanding the use of medication to address opioid use disorder. So there was just this total lack of referrals, internal and external. So that's, they laugh at me with my Southern accent here, but you all probably can live with it. This is one of those bless this mess kind of situations that culminated from both internal and external threats and just an overall lack of cohesion and alignment. And so this is the first case I've done with this form, so I'm just going to kind of follow it. The one thing they do have, or a couple things they really do have that are strengths, they hired a new director who is full-time, not just sitting in. He is stupendous. He went ahead and got ASAM trained, had never really done that before. He's been running the groups. He did the certification to actually be the supervisor for the peer. That was another barrier. And just hit the ground running. And he also got rid of some staff members who were misaligned by being very gentle and generous by saying, this is what we do here. Is this what you want to do? And they said, no, we don't believe in that. And he said, well, we've really enjoyed being with you, but we will find people who are aligned. So the nicest firings I've ever seen. And then we had really committed prescriber. They lost 2 prescribers during the pandemic. Both of them were absolutely not appropriate. Third was the charm. She is fearless, and so, and really understands the population very well. Very culturally aware and humble. She is not. Her humility is high, and so it's wonderful. And then the new director, right out the gate, wrote a grant to get a dedicated behavioral health addiction counselor to run the groups, because he's been trying to do that as well as do everything else. They also have an integrated care behavioral health PCBH model, so he was doing that too. So they have some really great, the hope bucket is getting more full. The leak is kind of plugged a little bit. But they need to get that patient census up. They need to start continuing to network in the community to get those external referrals. It would be great for you all, and they're really anxious to hear what your suggestions and recommendations are and what's worked for you when it comes to increasing community partnerships and increasing the communication within the organization in order to get the internal referrals. Also, how to address staff stigma that is a barrier to providing, I would say, the type of services that Be Well has been promoting through these your echoes. And then also staff retention and workforce development suggestions, because it is difficult to find folks who want, number one, who want to do substance use treatment in a health center during anyway, ready, set, go. What can you do to help them?
I think that was terrific, Kathy. For me, your audio went out right at the end, but I heard that last bit. Thank you so much. She's been jumping through hoops to make sure she had good connection with us today.
I guess what I just kidding. Yeah. Okay.
We heard at the end. It's It sounds like this group has been facing myriad challenges, internal and external, and I appreciate that clarification from you of what might be helpful from this learning community. So I think let's open it up to all of you. Any questions you have for Kathy about the scenario she described?
And you might want to put that, if you have the case again, if you want to put it back up if they can see it. I can also talk a little bit if you have a question about, I know that was a lot, but that second page yes, that might be helpful to see where some of the obstacles and challenges are so the community might be able to help us.
Thank you for the feedback in the chat about the form, and great suggestion, Kathy. More of that language in detail here. Any questions for her?
I have a question, and I apologize if I just missed it at the beginning. Kathy, you talked a little bit towards the end of walking through the case about trying to get your internal referrals increased. What type of screening do you do just for your standard like primary care appointments, not MAT specific appointments?
So being an integrated care site, using a primary care behavioral health protocol or model, they are using the basic depression and anxiety, a PHQ-4, which is 2 behavioral health or 2 depression and 2 anxiety questions, one from the GAD, the other from the PHQ-9. And so they also use the audit. We discontinued their use of the cage because it was invalidated. But because of the cultural sensitivity of the audit, they use the audit. And then they use a functional assessment and then a prepare. So if you're used to those, those sort of screening tools. And that's for all patients. They also have the craft for kids or adolescents. But they don't treat in their program anyone under the age of 18.
That's helpful. I think, a low-hanging fruit option to try to kind of drum up internal referrals is to give your MAs or your nursing staff or your providers, your MDs, an easy screening tool. So like the audit, at least the audit PC is pretty short, but that's alcohol focused. So like if you do like the 2-question screen for other unhealthy substance use or disordered substance use, and then have just some sort of reflex that sends any positively endorsed screens to your behavioral health counselor that I'm not sure if you have hired or you're going to hire. You're going to get a handful of, successful screens like those. You're going to capture those patients, for lack of a better word. You might get quite a few that don't want to have kind of further assessment, but that's a low effort way to just increase your patient traffic in your MAT clinic or your OBOT clinic, because those patients are already coming in for other needs, right? As opposed to trying to drum up completely external patients who are strangers, for lack of a better word, to your system.
Right. Well, they started with, and I appreciate that, they started with only patients that were their own patients, and then they lifted that to increase the census for those external. And the external partnerships that they had to develop also were for higher levels of care when someone identified in the program through whatever happened that they needed a higher level of care. But I really appreciate that. Our behavioral health consultants and the case managers had created their own kind of pre-screener for anyone for the OBOT to make sure that actually the person was appropriate. And that was a hangover from their previous medication program that they had. And that seemed to be a little bit too much. To me, it was more like the double stuffed Oreo, too much stuffing. So I got rid of that. And I agree, something a little bit more of a straight line. And they also put the prescriber as then the first line of, and I think that the prescriber actually even uses a Eureka.
Thank you for the suggestions, Alana. And other thoughts around increasing referrals, internal and external, for Kathy?
Hi, Kathy. My name's Richard. So one of the things that just occurred to me, and I don't know if your community has, or the state, if you have recovery-oriented systems of care groups, like where you have stakeholders and networkers in the community that are all kind of involved, whether it be the court system, drug court system, mental health courts, those types of things, clinics, substance use providers, recovery housing. Those groups that come together and meet on a regular basis, I think that might be a good place to, if you don't have that, maybe could create that type of environment, then you can create some referrals from that system as well. So I don't know if you have anything like that.
They do. And I think part of that is such a great point. And I think the assumption was the person who was coordinating was actually going to those meetings virtually during the pandemic, and that was not happening. But I think helping the director, who is actually new to the region, identify those. They did hire a new coordinator, but she's also not from the region. But if you have any ideas on how to identify groups that are not very obvious, because they don't always get invitations to those health centers, because, you know, it's not the usual place that you would probably send your invitations to.
Right.
But if you have suggestions, that would be great.
Yeah, the peer services, you have peer specialists certified, you have that program. So, you know, there's a pool of individuals there, community health workers and some of the others maybe on the ground floor in recovery housing, that internally, they all seem to know each other, right? And it's just kind of a small world in that circle. So that may be a good place to start.
And that's a great idea. And I think they assume that everybody else knows those too. And they don't necessarily.
Right. Yeah.
Thank you.
Kathy. My name's Rhoda Hall. I'm with Permian Care in Midland and Odessa. And when it comes to referrals, I think I know OSAR does a quarterly meeting for the different areas in Texas. That would be a good place to start to kind of get your program out there. As well as I'm finding a lot of referrals that I'm receiving recently for MAT services is coming out of Federal Bureau of Prisons, as well as TDCJ. So you might get with drug courts and you might get with FBOP, parole and probation, and see if you can get them engaged with your MAT services.
That's a great idea. In our region, the jail started prescribing naltrexone when someone would go in, and then they would go to the health clinic and start on Suboxone. They'd send them back, and then they would cut them off. It was just awful. So I think more coordination with our law enforcement and our places where people are, have lost their freedom. I do think that's a great idea. And I, wish we had more drug court participation.
Well, Federal Bureau of Prisons have began their RDAP program about a year ago, and they're just getting it up and running. So they're releasing to halfway houses with on Suboxone, and then they have 30 days to find a provider to get them into services. And so I'm seeing a big influx with that in my program right now.
Oh, that's a great idea. Thank you.
Hi, Kathy. I'm Sean from Fort Worth, and so we're using a lot of. Are you using literature at all? Do you have any kind of literature that you're handing out, or?
Well, so the program seemed to evolve in a very organic way. So to capture. Because the state regulations kept shifting, to describe it was really difficult. So patients because of the way that the providers in the region were sort of all over the map, if you weren't a preferred OBOT, you could still get your Suboxone, so you wouldn't have to go to group. And so we were trying to figure out a way to market it without sounding so prescriptive and so restrictive. We wanted to say you get all of these services in one place instead of, with your health care, instead of, and here's what also you have to do in order to keep your place in the program. So I think they're still working on that. If you have some suggestions for that type of literature or marketing, that would be great.
Yeah, we just went straight into the ERs and we talked to the charge nurses. And so when the patients would come into the ERs, the charge nurses would tell patients, here's a place to turn.
Wow.
Yeah. It was powerful.
So did the ER, is it part of a hospital system that has an OBOT or a medication program?
It was.
Oh, but they were willing to actually make a referral outside of their own system, because that was another barrier for this program.
They sure did.
Wow. That's awesome. You all must have a really good reputation. Did you all take folks who had sort of fallen out of the other programs? One of the things that I think they found was the census was also people who shopped the programs, and they would stay as long as they needed to, and then they would move on to the next one.
Yeah, we were finding out that they would stay 30 to 45 days. And as soon as the billing cycle would come around, they would hop to the next one. And it was just it was an all around bad deal, or we're still kind of gathering data on it, but what we're finding is it's kind of overdose to overdose type thing. It's confusing and frustrating, but
oh, absolutely. Well, finding the same thing here, but yeah, and I think figuring out the whole reimbursement and billing thing is just so hard.
Kathy, we're losing you a little bit, but I think I appreciate you summarized that challenge.
Thank you.
Reimbursement and billing. And I don't want to interrupt you because Sean was sharing some really great feedback there. It actually kind of bridges into another bit of this form, which I think, Carla, we've probably seen this. You can open up the room again and stop that screen share. But that's about how to talk internally with staff and clinicians and reduce stigma and increase utilization of these services. So I'd like to hear what you all have to say in terms of those kinds of recommendations. How do you train up your workforce? How do you reduce the stigma around this critical care?
I could speak to that maybe a little bit. When we first started doing our peer support work here, of course, that's a different paradigm, and the multiple pathways and all that was a big paradigm shift for a lot of our OSARs and people that had come from a clinical background that was not that. And so one of the things I think really helped fuel that was just there was an expectation from highest levels of leadership that this is our new norm. We know that it's going to require a gradual shift. So we need to hear from you. What do you need? What kind of information? And of course, there were required trainings and stuff like that we knew were good quality, that communicated the information well, and made sure that everybody had access to that. But it was also just that consistency. So in team meetings and staff meetings, all that kind of stuff, like the messaging, when it changed for good. And policy was rewritten to have more recovery-oriented, person-centered language in it. Like it just changed the entire culture. And so even when it wasn't spoken, there was still just this unspoken expectation of the shift is happening. I think they did a great job of not making it like get on board or get out. It was never that type of a conversation, but it was a much more engaging of what's the missing piece? What is still that disconnect? What is the barrier that keeps you from, still being able to buy into this? But a lot of it also was just doing the conversations of the clinical staff getting to be familiar with the peer staff specifically, and having opportunities created for those conversations to happen. And so it was, almost like a multiple disciplinary team meeting because the counselors had to figure out, why are coaches useful for me? That's great that they're going to go out in the community, but why should I care? How are they going to help me with my job? How are they helping me? Why should I refer to them? And all that kind of stuff. And so we had to have, conversations around cases so that they could start to see, well, these are the things that I'm faced with. These are the things that my clients are saying. And then we as peer could say, oh, well, I can help with that. Or I know somebody in the community. And so we had to have that opportunity created, though, to literally tell them how how we can be useful. And of course, it took time for that culture to shift, but gradually it did. And the ones that, even some peer staff that we had at one time that found, kind of like what was said earlier, that they couldn't really align with that paradigm, well then, they found other places to go. But that was a choice that they made. They were never, in that hard conversation of get on board or get out. So anyway, just some of those kind of strategies is what worked well for us. And now we have an agency that went through a name change and everybody's on the same page.
Oh, Sean, let me ask you, how did you deal with, at the beginning, when not all patients or clients were treated the same, when they had been identified as having an opioid use disorder or addiction, active addiction struggle? Because for some reason, the reaction to them, even this, our patients for OBOT coming into the health center, just coming in the door was very hard to, everyone. You could tell when people reacted, oh my gosh, they're here. And I'm thinking, they are the same people that you're treating upstairs for diabetes here. So I don't know why it's different today, because they've identified another thing that they're still struggling with, which is, we're treating just like we're treating diabetes. So how did you do that?
Well, I think, again, a little bit strategically, there were some of our, on the clinical side, there were some people that were more receptive at a quicker pace, I guess. And so when it came to, especially when we were really proactively doing a lot more of the MAT work, then they were the ones that really kind of got the streamline. Like, we just focused on them. They're the ones that are giving the positive messaging. They're not having the hangups and the slower paradigm shift. So let's just streamline everybody to them. And then we'll let the other OSARs, handle these other cases that they're just more comfortable with and all that. And then as they became on board a little bit more, or a little bit more accepting, then we could start spreading that around a little bit. So it was just kind of going for the quick wins. Like, what's the best way to do that? Who's already there that we can just align those people to? And then we even had kind of that same thing with coaches, to where if there were coaches that were more specifically already completely on board when it came to medication assisted treatment and harm reduction and all that, well, then let's partner them up kind of with those OSARs, and then that communication happens. And let's just do everything that we can to, avoid some of the stigma hangups and stuff like that. Let's align the people that are already in the same place, and then we'll continue to educate and inform and encourage everybody else.
This is terrific. How much, Sean, what you've just described reminds me of Matt's didactic, and that sense of aligning along a shared mission and working together in iterative cycles. Consistency matters so much here.
I was just thinking that I could have just had Sean do my talk.
That's what we often say.
That was really great, Sean. And you reminded me of this balance that I've been using a lot lately, which is empathy and accountability. And you really just embodied that in what you were describing, your system. A lot of empathy for the change challenge, but also a lot of accountability. This is what we're doing. This is our new normal. And it incorporated all those elements that we talked about earlier. So I really appreciated your sharing that.
Yeah, absolutely. I really enjoyed your presentation as well, and it felt good to feel like we had accomplished a lot of that, over the last 8 years or so. I think one of the other things that just came to mind as you were talking was it was important for us, though, to also communicate wins that we were seeing back to the clinical team, so that they could see, as people are taking this other pathway that's kind of new and unfamiliar to you, this is the successes. Here's these great outcomes. And so it was a little bit of that seeing is believing. And I think a lot of that kind of started chipping away at some of the barriers and the obstacles that we had. They had to see it. They really hadn't had that experience before. So we were able to help provide that for them too.
That is awesome, and a great reminder that this is a space to share those successes too. So we look forward to more conversation with all of you. Leslie, you get the unenviable job of summarizing a very rich session in case discussion. So have at it.
I'm going to try to talk as fast as I can because we have a minute or less. I'll remind everybody that there is in the chat box the link for the CE and evaluations for later. What we had earlier, people have just noted on it from Matt. I'm just going to say really briefly because there was just a little bit more commentary, is that reminder to monitor, measure, and effectiveness of our teamness and our teaming together. Ensure we have data-driven teamwork and ensure that your policy system.
Leslie, I think we're losing you a little bit. Going to see if we can we close your video and then we'll get you better.
Features are sustainable for that teamness and teaming. So always making sure that we do that. Kathy did a great job of describing a series of challenges in building and operating a substance use treatment programming, and commented on increasing partnerships, internal. Oh, okay. Can you hear me now?
We can.
Is this better if I talk here?
It is.
Hello?
Keep going.
Anybody?
Oh, Leslie, hello? Can you hear us?
Can you all hear me?
Yes, we can.
Oh, no. Oh, okay. I can hear you. Okay, I just turned off my my video from ensure that you start seeking out recovery groups in the community, different organizations. Consider a briefer screening tool with a reflex automatically to referral. Looking at your peer support and community health worker groups, recovering housing. Think about other quarterly meetings that might be happening in your state and areas, such as parole, probation groups. Courts, drug courts, reaching out to them related to referrals and information and resources. Consider addressing staff stigma outright. Look at developing literature. Also look at ED utilization and an automatic referral systems through there, or just making connections related to that. Considering that shift and really building the shift related to ensuring to reduce stigma and have open conversations with your teams related to that. Align your team members together, really building teams and doing active participation with that. Having messages that are recovery oriented, that are person centered, and ensuring that we always are leading with empathy and we have that underlying accountability. So I'm going to end there because I know I'm going to cut out again.
And I think what we're all displaying here is just adaptability to persistent and unexpected challenges, be they with Zoom or practice redesign. Well, I want to thank all of you for joining today's ECHO session. As a reminder, navigate up in the chat to find that link for the post-session survey to be entered into a drawing and to get your CME. If you want to present a case, you saw a great demonstration of our case form, please just email Andrea Hebler at utesca.edu. You'll get emails with all of this information. We look forward to seeing you at our next session next month. Thank you all for your time and your conversation today. Have a wonderful rest of your week.
Thank you, everyone. Thanks for all the help.